let's take a drug abuse history. It's a common scenario that you can find in psychiatry where you need to take history of someone's drug use. So, is there any chance you use recreational drugs? May I know what type of recreational drugs do you use? How do you take these drugs? How long have you been taking them? And do you use any other drugs? Who do you usually do the drugs with? And if you stop taking these drugs, do you develop any withdrawal symptoms? May I know what kind of symptoms you usually develop? Yeah, I get really anxious and fidgety. I start getting sweats and I'm just really not myself. Right. Thank you for answering that. I can see that it's really something that is unpleasant to go through. I just got a few more questions. Have you by any chance ever attempted to stop using drugs before? How did that go? If yes, how did that go? Okay. Good. We need to cover needles. It is a risk to share needles for HIV, hepatitis. Do you use needles and do you share needles? We ask if they use the needle exchange program. Do you know about the needle exchange program? Yes, I do. Do you use the needle exchange program? No, I don't. Is there any particular reason you don't use the needle exchange program? Sometimes I can't be bothered. Now, I want you to know one thing. When you say, do you know about the needle exchange program? If the patient says no, in management later, you need to explain to them what the needle exchange program is. The needle exchange program is a program where you can safely continue using needles by taking used needles and replacing them with newer ones. And this reduces the risk of you contracting infections from sharing needles. Okay? So by using a new needle, you reduce the risk of transmission, okay, from sharing needles. The reason people share needles is because maybe they cannot afford to go and buy new needles or it's not readily available. And so the needle exchange program, if I use a needle, I go and give this needle, I get a new one, and this protects the community. And so a common question is, well, why are we encouraging people? Why are we encouraging people to use needles? And so you need to explain, you should never inject yourself, right? So let me write down the explanation for you, okay? You should never inject yourself with needles. However, to safely do so, you can use the needle exchange program to swap old used needles with newer ones. And bloodborne viruses. So it's something like that. Mr. Johnson, you should never really inject yourself with needles. However, if you are doing so, you may want to use the needle exchange program to reduce the risk of catching an infection from using old used needles or sharing needles. They will take the old used needles and swap it with newer ones so that there is less risk of getting an infection or a bloodborne virus. And so I want you guys to practice different ways of saying the same thing. I want you to understand what we are really talking about. Safeguarding issues. When someone is doing recreational drugs, I told you guys already earlier, as part of what's being assessed, you need to recognize safeguarding issues in the population. Particularly, we're talking about domestic violence, we're talking about child safeguarding and adult elderly safeguarding. Safeguarding issues, you ask who else is at home? Do you use drugs at home? Are there any children? And do you ever take the drugs in front of the children? Now, you can also ask, have safeguarding issues ever been raised about your children? Have the child protection services ever been involved? When you're doing your social history, ask, where do you get the drugs from? What do you do for a living? And now we are entering socio-economic history. Remember, the scenario for drug abuse is mainly about taking a drug history and also taking the surrounding history that is important, which is social history and financial history And so we're asking how they fund themselves. We're asking if they've ever been in trouble with the law. We are asking about the support system, because when they want to quit drugs, it's important we know how we can support them. And so ask about siblings, ask about parents, and ask if they're in contact with their siblings and their parents. How is your relationship with your family? How does your family feel about you using drugs? Okay. And do you think your family and your partner would be supportive while you're trying to stop using drugs? So we did a good history. Good. Does your partner use recreational drugs? Anyway, we did 3 personal histories, and we will revisit these kinds of histories daily in the different scenarios. Medication history is very simple. Are you taking any regular medication, any over-the-counter medications, any herbal remedies, and the contraception? Allergic history. Are you allergic to anything? Do you have any known allergies? Are you allergic to any medication? Sometimes you have to be specific. When we're talking about pre-op assessments, we want to know if they're allergic to NSAIDs, for example. Okay? And you may need to ask specifically. Sometimes you have to ask specifically in the history of past medical history, do you have asthma? Because we know that these are things that will stop us. Sometimes a person has chronic back pain, or maybe you suspect they have ankylosing spondylitis. You may need to tell them, okay, so we do need to prescribe medications known as non-steroidal anti-inflammatory drugs. I just need to ask in the history about asthma and if they've ever had any ulcers or bleeding in the past in the stomach. Okay, so things like that will help you. If they smoke is also a very important question as well. So family history. Anyone in the family with a similar condition or problem? Has anyone in your family been diagnosed with heart problems, high blood pressure, high blood sugar, asthma, cholesterol, stroke? Again, sometimes you stay open. If you're doing a cardiovascular risk factor assessment, you need to ask specifically about heart problems, pressure problems, stroke. Maybe sometimes it's a palpitations scenario. You need to ask about the risk of a family history of sudden death. I'm sorry to ask you this, but has anyone in your family ever suddenly died? Okay, so because the referral criteria are in there. Travel history. Have you ever traveled abroad recently? Have you ever traveled abroad recently in the last 6 months? You need to cover 6 months for traveling. Okay. You need to cover the last 6 months. Occupational history is very important. And if they were retired, don't hesitate to ask him, what did you used to do for a living? For social history, we're talking about who else is at home. Is there anything that is causing stress in your life at the moment? Ask about married, ask about, who else is at home, ask about children. And then also take a social history. Do you smoke? If the patient has never smoked, ask, if they have ever smoked. Do you smoke? No. Have you ever smoked? No. Do you drink? And so one area that's very important is elderly history. When we're dealing with elderly patients, the social history needs to cover other things as well. They need to cover the activities of daily living, and they need to cover mobility history as well. For the elderly, we want to know if they're able to do the activities of daily living, such as shopping, cleaning, bathing, and the usual day-to-day things on their own. And we want to ask if they're able to move around on their own or if they use any support. So we ask if they live in a house or a bungalow, because a bungalow is one floor and a house can have stairs and can have multiple floors. We then ask them if they are able to walk independently. We'll ask if they have stairs at home. And if somebody is about to go for an operation, we also need to ask some of these things, because the social context is important as to whether we want to send them home or we want to actually keep them for a while for their recovery, especially if they live alone. So is your bedroom on the ground floor? Do you have to climb stairs? Where is the toilet? Things like that. Are you independent with activities? Yeah. Are you independent? Are you independent in your daily activities? Are you able to cook, wash, go shopping on your own? Do you have any carers or do you have any support that come and help? Good. So that's your PMAFTOSA. Is there anything else at all you would like to tell me? And we can now assess the effects as well. Okay. Assess the effects. So we do need to talk about the communication tools. When we are assessing the effects of the symptoms on the patient's life, we at least have to cover the usual important areas: the sleep, okay, the work, relationship, okay, sexual health. Sometimes somebody has angina, okay, and obviously you need to give them advice. This advice later needs to cover sexual health, and you need to also ask about that in history. Has this affected your sexual health? So sleep, work, relationship, okay, and sexual health, and different areas, very common areas as well. So we will continue to talk about each of the important areas as we do the scenarios. Now, urological question time. For urological questions, we are talking about pain. We're talking about pain on urination, okay? We're talking about signs of infection. We're talking about the stream. We take a Socrates. We ask if there's any pain on passing urine, if there's any burning sensation on passing urine, if they're passing urine more frequently. So more frequently is probably more than, when you hear frequency, they'll tell you, I go to the toilet maybe like 15 times a day. That's frequency. So when we're talking about frequency, it's more than 7, you could say. Okay. Any pain in the lower part of your tummy, ask about a fever, ask if they've ever had any infections in the past, urine tract infections, and if they have the urgency, you can ask the urgency early with pain and passing urine. For the stream, especially the older patients, when you're thinking about BPH, ask them, do you notice when you pass urine, you're unable to pass it straight away? This is about hesitancy. It takes a bit of time before the urination starts. Have you noticed that the urine stream is not like it used to be? Poor urine stream and flow. And ask if there's any dribbling at the end. This is the screening questions for BPH. If there's back pain, weight loss, you need to think about cancer as well, prostate cancer. Good. Some additional questions that you may have to do when it comes to rheumatological questions. This includes pain, stiffness, and swelling. So if I've got joint pain, I need to make sure I cover stiffness and swelling. For the pain itself, we take a Socrates. For the stiffness, we'll ask about what time the stiffness is worse. We ask if exercise makes the stiffness better. And we also ask if it's associated with joint pains and if there's any joint pains anywhere else. And we want to know about which joints are being involved. A good example is ankylosing spondylitis. For ankylosing spondylitis, they will have pain that wakes them up at night. It's worst at night. The stiffness is worse in the morning, and exercise and movement makes it better. And they will also potentially have associated joint pain or eye symptoms, which is, something that needs an urgent ophthalmological referral same day. Okay, anterior uveitis, right? You could also find somebody who has rashes because it's associated with things like psoriasis. And so you do need to make sure you cover that as well. And I'm going to go right ahead. I'm going to add rashes as well. Very important for rheumatology. Rashes and skin changes. Yeah. So if you keep your mind flowing like that and you recognize all the key types of histories in different systems, you will definitely prevail. Where is the swelling, if there's swelling? On the joints, okay? And ask about things like pain, redness, warm, and is there any rash in the body? It's added right there, but I made sure I put it in the beginning here to make sure you remember. Ask about a fever as well. Okay, good. Surgical question time. For your surgical questions, we're talking about pain, we're talking about lumps, we're talking about vomiting, we're talking about stool. Pain. We use the Socrates for the pain. For any lumps, we ask if when did they notice the lump, and does it feel like it's getting bigger? If there's any color changes, any redness, swelling, discharge, or bleeding, and if there's any pain and any lumps anywhere else. We may need to ask about vomiting as well. The amount, how often they vomit, if it's related to meals, if it's associated with pain, nausea, and the color of the vomit. So think to yourself, quality and quantity. For any of these types of things, quality, quantity. What does that mean? Even for a cough, I need to ask about the quantity and the quality. What color, okay, and how much? What color and how much? Very important. Other than that, for the stool, we need to know about constipation and we need to know about diarrhea. And so additionally, we also want to know for diarrhea, especially, and we'll do these on the day, we need to know about the color, the frequency, okay? And if it's loose stools or watery. Good. So we are now almost ready to start scenarios. I've given you a rundown of the different kinds of histories that you'll find taking. And I just want to make sure I highlight the key areas. The key areas are, I am going to be taking a history. I need to know my presenting complaint, and then I should have 2 to 3 of the main differentials in most stations. And then I will take a background history. Somewhere in here, your communication tools will be applied. When you're taking history, communication tools will include signposting each part of history. And after you take history, ideas, concerns, and expectations. So when do the effects come? The effects of the symptoms on the patient's life comes after you've taken a full history. Whatever history that you've taken, you now need to say, can I know about a bit more about how your symptoms have affected your daily life? Has it affected your sleep? How has it affected your work? Has it affected your relationship? Okay. Does it make you feel down? Anxious? And that's how you will cover the psychosocial aspects. Remember, it's biopsychosocial. And really and truly, the bio is done through the initial history. That's how you know about the disease symptoms and its progression and how it's affecting the person. You need to ask for the psycho and social effects on their life and if it's causing any psychological symptoms. Does it make you feel down? Does it make you anxious? So we talked about the presenting complaint, the Oedipara, the Socrates. The differentials will be yes, no questions to identify key areas in differential diagnosis. P. maftosa, ice, and effects. What examinations will you likely find yourself doing in your stations? You will usually need to do your observations. This is to check the blood pressure. This is to check the pulse, the oxygen levels, and also the respiratory rate and the temperature. Again, tell your patient, I'd like to do your general vital signs, and make sure that you at least say you would like to check the important ones. So if you want to check someone's blood pressure mainly, you don't suspect any problems with oxygen, you can keep it brief and say, I'd like to check your general vital signs, make sure your blood pressure is okay, and that your oxygen levels and everything is fine, very briefly. I'd also like to do specific examination time. I'd also like to do a respiratory examination or a chest examination. This will involve me having a look, feeling tapping and listening to your lungs. And so there's two types of consent taking you need to know about. There's one where you actually need to perform, and there's another one where they give you findings. So I'd like to do a series of examinations. I'd like to do your blood pressure, your heart rate, how fast you're breathing, and your temperature, check your vital signs. I'd also like to listen to your heart and lungs. I'd like to tap and, have a look at your chest, tap on your chest, feel your chest, and also listen for any abnormal sounds of breathing or heart sounds. So when you do this, and it's actually examination time, the patient needs to say yes. If the patient says yes, what do you need to do? You need to explain adequate exposure. So when you're doing adequate exposure, please remember one thing. So when you're doing adequate exposure, you need to first have explained what examination you'd like to do, and they need to say yes. Okay, so I'd like to do an examination of your tummy. I'd like to have a look at your tummy. I'd like to, touch your tummy and feel for any lumps and tap on your tummy, as well as listen to your bowel sounds. Is that okay? Yes, that's okay. Thank you. For the purpose of this examination, I do need you to be undressed below your chest and up to your mid-thigh. I will, ensure your privacy. And for this examination, I will also need a chaperone. And so this is how you do the process. If it's a regular history taking station, by the time you mention the examinations, they will hand you the findings. But again, we are always prepared. Bedside tests will include urine dipstick tests, pregnancy tests, and ECG, blood glucose, CTG as well. Depending on the scenario and situation, you can do bedside tests.